Hello all, welcome to my show Chronicles of a Loner RN, and thank you for listening. My name's Ritika, and I'm a registered nurse working out of Melbourne, bringing my experiences and learnings to a wider audience. Today we'll be talking about advanced life support and how this plays out in reality with two cases that occurred recently. As a disclaimer, I will not be providing any personalized information. All names, numbers, and results will be altered to protect the privacy of the patients this story is derived from. For context, I was not a part of the resuscitation efforts for either of these patients. I have my own reservations about this, which I'll delve deeper into later in the episode. Case study 1 was a young middle-aged lady that had come into the ED after 45 minutes of CPR carried out by AV, who was able to achieve ROSC, which is return of spontaneous circulation. But while attempting to maintain this ROSC, she crashed again and subsequently, after a further 30 minutes of life-saving interventions, was pronounced dead. Case study 2 happened quite literally 24 hours later. He was an older gentleman who had a code blue outside in the car park. CPR was started and continued for about 45 minutes before calling time of death. Case study 1 had a relevant history of a respiratory illness for about 3 days prior to arresting, which may be a contributing factor to her untimely death, but it is uncertain until further testing is done. But for case study 2, though we were unable to get any history at all, and as a result of this, his cause of death is unknown and will not be known until the coroner's report is done. All deaths that are essentially the result of anything but palliation or natural causes is investigated by the coroners. This includes obvious cases like murders, victims of accidents, victims of attacks, people with unknown causes of death, like our two case studies. But another one that people don't think is a coroner's case, but usually is, are elderly patients that die as a result of an incident within nursing home. Say, for example, you got a 91-year-old who's fallen and has now got a brain bleed, but also has a whole host of other conditions like end-stage heart failure or advanced stage cancer and is currently palliated. Now, I just said that palliation usually doesn't go to the coroners, but given the patient passed away while being treated for the injury, the case becomes a coroner's case to determine what actually caused the death and whether there was negligence involved that can be fixed, whether the fall killed him or killed them, or one of their other conditions. It is highly likely to be either one impacted the other, or just flat out the fall was the reason. If they had not had the fall, they likely could have lived longer. Unfortunately for cases like these, and in a system with a backlog as long as the width of the state, there is understandably a delay to the resolution of these cases, which can negatively impact the family, not having access to the body of their loved ones to put to rest. But next we will discuss advanced life support, or as I'll be calling it, ALS basics. What I've learnt, comprehended, and how I understand the ALS algorithm to work. For clarity, today I'll just be going through the ANDS Core Adult ALS algorithm, with no mention of the Taki-Brady algorithms, nor the pediatric and neonatal ALS algorithms. ALS. Where do I begin? Maybe another quick disclaimer. ALS is to be run by experienced and accredited healthcare workers in a medical setting. ALS cannot be done in the community by bystanders. In the community, BLS, or basic life support, is what must be done with an AED or an automatic defibrillator, doing all the ALS side of management. I'll explain BLS to those keen to learn at the end, so stick around. Advanced life support is a complex and heavy concept to grasp in theory, let alone in practice. Today, I'm going to run through the algorithm and basics. As they say, you don't really understand a topic until you can teach it to someone else. So buckle up, because this might be a huge mess. Apologies in advance. The algorithm itself is pretty straightforward. It assumes that the first responders have commenced BLS and CPR has begun at a rate of 30 compressions at 100 to 120 beats per minute to 2 breaths with a bag valve mask. Don't do mouth to mouth. At the earliest opportunity, get the defib pads and place them on the right pec and the left side of the chest. Usually the pads will have a diagram of where they need to go. We do not wait to do a rhythm check. Once the pads are on, we go straight into the coached approach. The coached approach is an acronym designed to limit the risk of error and harm when dealing with and delivering electric shocks. So I'll go through it quickly before continuing on. C is for continue compressions. It is important, even when the device is charging and everyone has stepped away, that compressions do not stop until the last second, because it is compressions that save lives, not the shock. O is for oxygen away. Free-flowing oxygen cannot be near the patient when we deliver electricity, as a spark is all we need to start a fire, and we do not want that. A is for all else clear. Anyone that does not need to be touching the patient or the bed needs to step away, and it is important, as the person doing the defib is to ensure that everyone is away by checking the top, middle, and bottom of the bed. C is for charging. Compressions do not stop. The machine will audibly charge and tell you when it is ready with an alarm. Once it is charged, only then do compressions stop. H is then for hands away. This is the final warning for those that haven't stepped back yet, and for the person doing compressions, telling them to stop and ensure that they are safe away from the patient. E is for evaluate rhythm. As we'll discuss later, not all rhythms are shockable, and CPR rhythm looks an awful lot like VT, which is a shockable rhythm. That's why it is incredibly important to assess the rhythm without continuous CPR. D is for deliver or dump. Depending on the rhythm seen while evaluating, we either deliver the shock or dump it, meaning the machine throws it away. At this point, as the person on defib, it is important to remind everyone to continue compressions and bring back the oxygen, because you might think it's obvious to restart compressions, but the compressions person may just be waiting for you to tell them it's safe. That's the coached approach in a nutshell. We use an ALS and for cardioversion, which I'll discuss in our episode on atrial fibrillation. Continuing on, once we have the pads on and have started our coached approach, we now have to decide which pathway we need to take, shockable or non-shockable. Shockable rhythms include and are limited to VT or ventricular tachycardia, VF or ventricular fibrillation. Two heart rhythms that we'll dive into another day. But once it's determined that the underlying rhythm is a shockable rhythm, we give the shock. We start at 200 joules, and this increases to 360 joules for every subsequent shock, but if it's required. After the second shock, we'll give 1 milligram of IV or IO adrenaline, and after the third shock, we'll give IV or IO 300 milligrams of amiodarone, an anti-arrhythmic medication to reset the electrical rhythm. Once that is done, and still, if not working, we continue to shock every 2 minutes at 360 joules, and continue with 1 milligram of IV or IO adrenaline every 4 minutes, or every second cycle. For those that don't know, IV is intravenous, so we put it in your vein. IO is given usually in kids as a first line, and in the event we cannot find a vein to cannulate, we'll drill into your bone, what's called intraosseous, into the bone marrow, and we can give medications that way. To be honest, it is quite effective. In this situation, you likely won't feel the drill, so you shouldn't be too worried about a loved one or anything like that that gets an IO in this situation, because I can guarantee they won't be feeling it. Now, we'll move on to non-shockable rhythms. So non-shockable rhythms include the well-known asystole or flatline. It's a tough concept to understand because I've heard a fair few times, like, how doesn't the shock restart the heart? Like how you restart a car engine. Like Dr. Mike says in his video on the HBO's The Pit, episode 7, go watch it if you haven't. The defib restarts the electrical circuit of the heart if there is an unstable rhythm and allows the heart to restart on its own. That's the main thing. It restarts on its own. But the caveat is that it needs to start on its own. Therefore, in asystole, when there's nothing coming from the heart, a shock can't restart what's already not working. That is why we need to give medications, like adrenaline, to really get the heart pumping. And that's why CPR is so important as well, because in asystole, the heart is not moving. We are pumping what is left of oxygenated blood around the body. But another non-shockable rhythm that can trip people up, actually both non-shockable rhythms, there's only two, but they can mess people up too, is a PEA arrest, or a pulseless electrical activity arrest. You might see on the monitoring that there's normal electrical rhythm. You might see just, the normal squiggles you'd be seeing in you or me or anyone else that's, alive. But the heart is not beating. This too is a non-shockable rhythm because there is nothing wrong with the electrical mechanisms of the heart. It's the mechanical heartbeat that is not working. And this can only be fixed with good CPR and medications. That being said, the medication list for non-shockable arrests is rather easy. It's just 1 milligram of IV or IO adrenaline every 4 minutes or every second cycle. Now we'll discuss the reality of using the ALS algorithm with the case studies. Case study 1 had been sick for a few days before passing away. Sepsis is a whole body response to an infection, and if not treated, can lead to death. Now, when she arrested again, I was told she was initially in a PEA arrest. Now we know that a PEA arrest is a non-shockable rhythm. They began compressions and worked through the non-shockable pathway until time of death was called. In reality, this looks like the first responder is on chest compression. You press the emergency buzzer and then you get on the chest. For no more than 2 minutes, because if you do CPR correctly, you should be tired by the 2-minute mark. I know me personally, I make it through the 2 minutes, but if I am the main person on compressions, which I was until ALS certifications, then after 3 to 4 rounds of CPR, my arms, my back, my neck, everything just got tired. I was profusely sweaty and my compressions got worse. That's why it's so important to have a few people to rotate through every coached approach so that the quality of the compressions does not fall. Everyone else that comes to help will be assigned a role that's either airway, circ, or scribe. Airway nurse will help set up for a rapid sequence intubation or help oxygenate the bag valve mask. Everything regarding intubation, rapid sequence intubation, delayed sequence intubation, bag valve masks, airway adjuncts, everything we'll discuss in another episode. Circ nurses, or circulation or drugs nurses, whatever you want to call them, will make up and potentially administer all the medications that may be needed. In this case, primarily adrenaline. There are a plethora of medications we give in an arrest that are not directly as a result of the algorithm. I'll discuss this at the end. And for case 1, this is what would have happened. CPR, coached, dumping the charge, giving adrenaline, and other medications to hopefully reverse the cause of the arrest, and repeat until it's obvious she's not coming back, or she does come back. Unfortunately, in this case, she did not. Now, knowing what we know about how to deal with the non-shockable rhythms and how this was the case for case study 1, there isn't anything different I can say for case study 2, to be honest, except that he was in asystole instead, and unfortunately he too could not be saved. Now, before I talk about my thoughts about these cases, I wanted to give a brief overview of the 4 H's and 4 T's. Before I said that there were a plethora of medications that we give even in non-shockable rhythms that isn't just adrenaline. This is because the cause of an arrest is one of 8 possibilities. The 4 H's include hypoxia, which is critically low oxygen, which leads to cardiac muscles stop working. Hypo or hyperthermia, so low temperature, high temperature, can affect the uptake of oxygen. You may have heard of it if you're aware of it, you may have heard it being called the oxygen hemoglobin dissociation curve, the oxyhemoglobin dissociation curve. This too stops the cardiac muscles from working. Hypovolemia, which is a word for the lack of circulating blood volume, leading to too little blood and oxygen reaching tissues, and eventually the heart stops working. This can be due to infection or injury. We'll go through the different types of shock, septic shock, how that leads to hypovolemia in another episode. There's so much we have to unpack, guys. Hypo or hyperkalemia, either high or low potassium, other way around, respectively, either low or high potassium. It's a killer. Potassium is essential in the electrical circuit of the heart. Without the right amount, the heart can begin to stop working. And then the 4 T's include cardiac tamponade, which is when blood fills the sac around the heart, and the pressure that this fluid builds can't allow the heart to beat effectively. Tension pneumothorax, so the lung has collapsed, putting pressure on the big vessels, leading to reduced cardiac output, and therefore the heart will eventually stop beating. You've got toxins / drugs / poisons, have a multitude of effects, can cause respiratory depression, which can cause a heart attack, can be toxic for the heart, and may cause altered electrical rhythms, like prolonged QT. There'll be an episode soon where I go through all of the different sort of ECG changes, the blocks, medications, what this can lead to, and then how this can lead to us getting back to the ALS algorithm. I'll discuss that in another episode. Thrombosis, a blood clot, usually in the lungs called a pulmonary embolism, stops the flow of blood through the lungs, reducing how much oxygen and carbon dioxide gets exchanged, leading to cardiac muscle dying, etc., etc. You get the picture. The reason the 4 H's and the 4 T's are so important in any arrest situation is because if you don't figure out the cause, they're just going to arrest again and again and again, and we don't want that because it's too much work. Examples of medications we can give include, like for hypo or hyperkalemia, either potassium if it's too low to replace the potassium, or if it's too high, we can give calcium gluconate versus calcium chloride. This stabilizes the cardiac membrane. And then insulin and what we call dextrose, which is just sugar, to get rid of the potassium. Now, the pathophysiology of how insulin and dextrose gets rid of potassium is very interesting, and I will go through it in another episode. I feel like that's all I'm saying today. This. We're just going to get through it in another episode, but I promise I will. Hypothermia, we can give warmed fluids, warm blood. Hyperthermia, we can give cool fluids. Hypovolemia, we can give intravenous fluids, inotropes and vasopressors, which I'll discuss in an upcoming episode about sepsis. Toxins, we can give the treatment as outlined by Oxygen Tox, but that's if we know what they've taken. Often we don't, and we just sort of have to guesstimate based on the symptoms they had before they arrested. And thrombosis, we give clot busters to, bust the clot and restore blood flow. While we are going with medications and CPR, other things are going on too, like ultrasounds of the heart to determine whether there is fluids, say the cause is a tamponade, or whether there is any intrinsic activity, like a clot that's reducing the function of the ventricles. You'll be able to see that. Now, we are all no strangers to the inevitable feelings of jealousy when we see someone doing or experiencing something we want to see or experience. I am no different. When I heard my friend, who I'm currently studying with, got to be a part of the arrest, I was jealous. Like, why is it that she gets to, for lack of a better euphemism, pop the arrest cherry? All my experiences that I mentioned before, how I know I sweat a lot and I can get through the 2 minutes, they've been because of manufactured simulations and scenarios. And I'll be first to admit that I have not done CPR on an actual human before in my 2.5 years of nursing. And now that I'm working in the highest acuity area in the ED, it's only a matter of time before I do. My qualm is that I know my first experience will be terrible. I'll freeze, I'll not know what to do. Everything I've just explained to you will leave my mind instantly. But the sooner it happens, the sooner I can begin to work on bettering myself, using the real life situation as a memory and a motivator to do what I do well again and to not do what I did terribly again. This may sound crass and insensitive for those that do not understand the pressure of knowing something in theory and just waiting for the first practical to go wrong. A lot of people know the theory and they go about life thinking they'll ace it if the situation arrives. But I am acutely aware that in my case this will not be true. I'm going to mess up. It'll make me feel horrible, but it needs to happen for me to be better. And now it's just a waiting game until that happens. And I've just missed 2 opportunities back to back because I wasn't on the right shift. It happens. Doesn't mean I don't get to feel slightly jealous of my friend. Now, it's often stated on social media and dramatized on TV the toll that attempting to save a life and losing it has on the conscience. I do not think it can be overstated. This on top of all the things we have to deal with on the regular, like aggression, violence, high acuity, bed blocks, the departmental pressures I mentioned last episode. It all adds up. We burn out so fast because we hold on to so much and are just expected to deal with it and come back the next day and do it again. A colleague of mine was present and actively participated in both arrests, both patients she lost. She says she's okay, and I don't want to push it, but if that was me, and to be honest, I'd not be okay. But unfortunately, I have this terrible trait of not wanting to divulge my traumas, so I do probably say I'm okay and go about my work like anybody else. This is not the solution. It's happened to me before. I think I can just forget and move on, but that doesn't happen. It sticks with you. It doesn't leave you until you're a shell of who you used to be. And at that point, you hate your job. You hate your patients. You have no empathy left. You don't care what happens. This is the side of healthcare workers people don't think about. In traumatic events like 2 failed resuscitation attempts in 2 days is enough to push people over the edge. If anything, just keep that in mind next time a nurse looks flustered, isn't attending to you fast enough, or just seems distant. That being said, the community we forged at work ensures that everybody knows they are not alone. We do debriefs so people can get what they need to off their chest. They can cry, they can scream, they can say what did well, they can say what we need to do better, and they can grieve, all in a safe, supported space, so that they can go back out there and give the rest of the patients they need to see the same support and attention that the deceased received. My apologies, that sentence did not come out right. Unfortunately, the ED doesn't close after death. So without this support system, it would be inhumane to ask these nurses and doctors that just witnessed a horrific death, emotionally and physically exhausted, to just put a smile on their face and do it all again like nothing happened. Wow, that was a heavy section there, not gonna lie. But it needed to be said. Now I'm gonna give back and teach something useful for community scenarios. To preface, please don't take my words as medical advice or do or don't teachings. I'd advise going to an accredited BLS training course and getting taught, by people that actually teach BLS. But if you're in a pickle, I can give some tips and tricks to remember until help arrives. If someone is found non-responsive and they are not breathing, you do not need to check for a pulse. If they are not breathing, their heart is not beating. Once you know they are not breathing, you should begin chest compressions immediately and yell out for help. There's a mnemonic they teach us, Doctors ABCD. Running through it can help with the steps. So we'll start with D. D is for danger. Are there any sharps, exposed wires, or any other dangers that could endanger you when you try and help this person. Then we go for R. R is for response. Call out, shake them, squeeze their trapped muscle with exuberant amount of force. Make them hurt. If they wake up to pain, that is a good thing. If they don't, though, we go to S. Send for help. Yell. Get someone to call 000. Get someone to find and bring the closest AED if available. Then we move on to airway. Have they vomited? Is there something stuck? If so, attempt to remove it if you have the capacity, but don't stick your hand in their mouth. Don't want to get bitten. Then we go to B. B is obviously for breathing. Check for rise and fall of the chest. Could be minuscule, so get the clothing off to actually see the chest. And by minuscule, I mean if their respiratory effort is so low and they're taking such shallow breaths, they could be breathing very, very slowly and on their way to not breathing, but they could be breathing. But you need to get all the clothing off so you can actually see. See? Like I said before, if they aren't breathing, start chest compressions. At the bottom of the sternum, 2 hands, arms locked, using your whole body, not just your arms for strength, to push 1/3 of the way into the chest for good compressions. This should be done at a rate of 100 to 120 beats per minute. You can use Staying Alive by the Bee Gees as a good rhythm. This should be done 30 times before giving 2 breaths. But I must, and this is very important, I must state again, do not do mouth to mouth, especially on a stranger. You don't know what they've got, what bacteria they've got in their mouth, if they've got some sort of virus that they could be giving to you, like the flu or strep A, which have been incredibly deadly this year. If you do mouth to mouth, it is a one-way ticket to you getting some sort of disease. So don't do it. Don't do mouth to mouth. Good compressions can hold off until a bag valve mask arrives. The only exception to this rule is if it is a child that is needing CPR or a drowning victim. Then rescue breaths is before compressions are a must. D. Hopefully at this point, either the paramedics are taking over or someone has bought an AED. Apply the pads as instructed and turn the machine on. Listen to the machine very carefully and do exactly what it says. It's got that ALS algorithm programmed into it and will determine whether to shock or not. All you need to do is to listen when it says to stop compressions, stand back, and continue compressions until help arrives. It is ideal that once you've called for help, a lot of people are likely going to come and watch. Mobilize them, but never ask the general population to do something. You need to lead as a first responder. Explicitly tell someone what you want them to do. So for example, if you want someone to call 000, you make eye contact with them and you go, you, yes you, call 000 now. Tell them we've got a cardiac arrest and CPR has begun. Let them go do that. If you need more people, if no one's volunteering for the lovely job of chest compressions, you need to mobilize people. Go, you 3. Describe the people you're looking at so they know you're talking about them. Go, come behind me. Watch how I'm doing these compressions. When the machine says to stop, I'm going to tap out and I need you to step in so I don't fatigue. It has been shown to be incredibly more effective to tell people what to do in emergency situations rather than get the question out and let them figure it out amongst themselves. Because then nothing will happen, you'll fatigue, and risk of mortality will increase. I hope this doesn't happen to you the way I know it's coming for me as an inevitable, but hopefully just keeping this acronym in mind will help you survive until help comes to relieve you. Or even better, you can help someone else who is trying but may not be getting it completely right. Another point I want to touch on before we wrap up for this episode is that it's so easy to get task-oriented and in the moment, but it's always good to remember that this person has a family too. And if they're around, make sure they're not unsupported. whether that be taking them out of the situation and with someone that can explain, or if it's a child, allowing them to be present and don't leave them alone. The scenes are so chaotic for someone looking in, it is very difficult to discern what is going on, what is actually being done to save their loved one's life. Empathy goes a long way in these situations. To recap what we've learned today, because it's a lot, we've learnt the bread and butter of the adult ALS algorithm. We've learnt about shockable and non-shockable rhythms, what to do, what to give, and how to shock when appropriate using the coached approach. We've learnt about the reality of ALS situations and how it feels as a healthcare worker to be involved in 2 unfortunate arrests that were both non-shockable and both unsuccessful. We've learnt about the 4 H's and 4 T's, why they're so important, and I got to unpack my feelings about my own jealousy and the emotional toll I believe this has on all of us. And we've gone through BLS pointers to get you through before you get the chance to take a course. Because you're going to take a course, right? Right. So this wraps up this episode of Chronicles of a Learner RN. I certainly have learnt a lot, and I hope you have too. I have a plethora of cases and learning experiences I am excited to share with you, those of you that are willing to listen. If you enjoy what I do, what I say, and what I can bring to the table, then please subscribe to the podcast. It means a lot.